So we're going to be talking about B12 neuropathy, and the one that matters to us is the optic neuropathy. And the way that presents to us, just like any toxic or nutritional optic neuropathy, it's going to be bilateral and symmetric. Because the papillomacular bundle is highly metabolically active, it causes a central scotoma and loss of central acuity. So it's the opposite of pressure-related phenomenon, which causes constriction of your visual field from nerve fiber layer loss and spares the center. In toxic and nutritional optic neuropathies, it preferentially involves the center. And that's because that's the most metabolically active portion of the retina. And so if you're looking in the back of the eye, the fovea, it is this papillomacular bundle that causes that central scotoma, and that is what is affected in B12 optic neuropathy. So you should be thinking about toxic and nutritional optic neuropathies when confronted with a painless progressive bilateral central acuity and central field loss. The nerve might be normal initially, but eventually it's going to turn pale, and OCT is going to show that the papillomacular bundle is out, corresponding with the temporal pallor on the optic nerve on the fundus exam, but it can be normal initially, and we'd actually like to diagnose it before the pallor occurs. So when should you be thinking about B12 neuropathy, assuming the clinical scenario is suggestive of a toxic nutritional optic neuropathy? Risk factors. The risk factors you're going to be thinking about are intake, dietary risk factors, eating disorder, anorexia, bulimia, or they're a strict vegetarian or vegan that is limiting their B12 access, or it could be an absorption problem. That absorption problem can be anywhere from the stomach, which produces the intrinsic factor, and the parietal cells make that intrinsic factor, and so autoimmune antibodies against intrinsic factor or against the parietal cell or gastritis can lead to B12 deficiency. And then you move down the small bowel in terms of the ileum and the duodenum and the jejunum, where the B12 is absorbed. So it can be both gastric or small bowel. And so if they've had any kind of surgery, bariatric surgery, or if they've had any disorder of their gut, regional enteritis, Crohn's disease, any kind of surgical procedure involving the gut, or if the person has the autoimmune condition, which in the book says causes megaloblastic anemia, but in the real world, they often don't have the anemia. It can also be B9, and we're not talking about B9 today, but it could be either, so you have to test for both. B9 is folate. And B12 is the cofactor in the conversion of methylmalonyl-CoA and methylmalonic acid to succinyl-CoA, the entering molecule into the Krebs cycle. And so if you have B12 deficiency, you'll have an elevation in methylmalonic acid. It's also involved in the conversion of homocysteine to methionine, which is also a B9 process. And therefore, if you block, you'll get elevations in homocysteine. So testing for both the methylmalonic acid, the homocysteine, and the B12 level are usually necessary to make the diagnosis of B12 deficiency. And the particular combination you're looking for clinically is optic neuropathy plus peripheral neuropathy, a stocking and glove distribution peripheral neuropathy. That combination is highly suggestive that it is vitamin B12 deficiency. You're going to test them, and then the treatment, of course, B12.